So, hello, everyone. Thank you all for being here, and thank you, Dr. Ellen Bogie, for that introduction, and thank you to my colleague Richard for that technological preface to my presentation, which will be a little more clinical. My name is Yahir Gonzalez Valdez, and today I'll be presenting on determining patient care utilizing computational fluid dynamics. So to provide some context as to what computational fluid dynamics has the potential to do in the future, I would like to start by highlighting aneurysmal subarachnoid hemorrhage, which remains a crucial cause of stroke mortality and morbidity in patients presenting with aneurysms. Aneurysmal subarachnoid hemorrhage occurs when a blood vessel in the brain bursts, aka when an aneurysm ruptures. This poses a great challenge for physicians when deciding whether an aneurysm requires treatment or not, as the prevalence of unruptured intracranial aneurysms is said to be as high as about 7%, but only a fraction of unruptured intracranial aneurysms will inevitably rupture and/or require surgical treatment, with surgical intervention itself posing elevated risk of potential rupture. However, using the novel technique of computational fluid dynamics, physicians may one day have an additional tool that provides them with relevant information regarding the treatment of intracranial aneurysms and the risks to consider prior to surgical intervention. And so here's a general schematic of how we generated our CFD models. First, we acquired 3D rotational angiography datasets, which are part of standard patient care and are in no way invasive towards the patient. We use these datasets to extract aneurysm repair vessel geometry, which then we can use to generate a volumetric computational mesh. With this volumetric computational mesh, we can then run it through a sequence of different software and code in order to do CFD data analysis, in order to produce hemodynamic parameter data that we can then utilize to extract relevant information regarding the patient's aneurysm. And so next I'll do a CFD case study focusing primarily on application and then literature review, but I would like to add a disclaimer that computational fluid dynamics is not yet utilized in a standard patient care setting, and that the case study that follows is what the scientific community is striving towards in regards to CFD from a clinician's perspective. For CFD to become clinically viable, as my colleague Richard has mentioned, parameters must be patient-specific, and that is the main takeaway message. And I will touch on this later on in my presentation as well. What we do know right now is that every patient is unique when it comes to their blood thickness. Whether the patient smokes or has hypertension will all impact their blood viscosity. And research has shown that small changes in viscosity can lead to detrimental changes in critical hemodynamic parameters of interest, such as wall shear index and wall shear stress and oscillatory shear index. The first two graphics are from a study that show in aneurysm A, when the Newtonian model is used, there's an underestimate of blood viscosity, which leads to an overestimate of wall shear stress at the aneurysm dome. And this can be potentially problematic in certain cases as the slow recirculating nature of blood in aneurysms with wall shear stress that is actually low will lead to aneurysm expansion and ultimately rupture in some cases. Another thing that CFD can be utilized for is to predict thin-walled regions, which is this third image here, also from a study. And thin-walled regions are thought to be areas of elevated rupture risk. In that interesting study that I mentioned, neurosurgeons were asked to identify thin-walled regions visually from an intraoperative video. And CFD was used to calculate areas of max pressure and low oscillatory shear index to identify the thin-walled regions. They found that in about 82% of cases, the CFD pressure maps were consistent with what the neurosurgeons were able to visually identify using the intraoperative videos. And so here are some preliminary results from our case study in which we looked at a patient that presented with a 15 millimeter internal carotid artery aneurysm. We assessed it for different parameters such as wall shear stress gradient, and OSI, both for the aneurysm pre-treatment and post-treatment. We focused on viscosity in particular, that being standard blood viscosity values and patient-specific blood viscosity values. As seen here in the data table, there was a 20% change between the standard viscosity and the patient-specific blood viscosity, which resulted in high percent changes in all parameters of interest. The illustration to the right looks at oscillatory shear index in particular, in which we see that there was roughly a 13% change in the post-treatment, and then a greater percent change of up to 40% in the post-treatment. Because viscosity is governed by nonlinear systems, as mentioned in the previous presentation, we need to account for viscosity actively when analyzing aneurysm CFD models. As I mentioned before, a study suggested that areas with low OSI are associated with thin-walled regions. So theoretically, if a physician were looking at this in the future, when CFD is utilized in a clinical setting, adopting standard blood viscosity values would result in inaccurate results and an underestimate of OSI, which may be misleading for physicians when identifying said thin-walled regions. Long story short, the complex nature of aneurysm hemodynamics requires that scientists utilize patient-specific detail to ensure that simulations are as accurate as possible. On a similar note, to move forward with CFD research in hopes of it one day being utilized in a clinical setting, the scientific community may consider standardizing the tool and using patient-specific parameters. There are a number of parameters. I remember reading a systemic review that showed up to 81, which is a lot. And many of those are there's still debate as to how they contribute to aneurysm rupture pathophysiology. So determining a more definite criteria for CFD analysis on aneurysms would be a great leap forward. Moreover, progress needs to be made in terms of specific parameters worth evaluating when factoring in treatment success. Furthermore, there is opportunity for meta-analysis between research studies and aneurysm rupture risk preventative tools. Physician scientists can learn more about the molecular pathology of aneurysm formation by comparing different profiles based on rupture risk and seeing if there's a difference in regulation and expression of particular endothelial markers associated with hemodynamic stress. One study that Richard and I were able to contribute to this summer was the endovascular biopsy study. Computational fluid dynamics is relevant here as one of the vascular factors of aneurysm endothelial cells is ADAMTS1. ADAMTS1 is found to be upregulated in areas of high wall shear stress and high wall shear stress gradient. So in the future, CFD may be utilized to give grounds for endothelial cell collection during endovascular surgical procedures. More broadly, CFD may be used as a tool to compare results regarding the physiology and biochemical mechanisms associated with aneurysm formation and rupture, which can ensure consistency across studies regarding aneurysm. And with that, I would like to thank everyone who made this program so memorable, including Dr. Ellenbogen, Sylvia, Julie, and the rest of the team for having such a great idea of what medical education should be. I would like to thank my PIs and mentors over at the SANS lab, Dr. Levitt, Dr. Fillingham, Keiko and Christine, and the rest of the lab mentors for supporting us throughout the summer. And I would like to thank everybody who showed up today, as we couldn't have done it without our village. Thank you all.